Well, first of all, thank you for having me. And it's really a pleasure to be here. And I have learned a lot. But I have to say that Tracy, using a Brazilian expression, you broke my legs yesterday when you said that non-seizure symptoms, you just don't care. And for someone who just don't care, I have to confess that you have done a great job showing that non-seizure symptoms, especially cognition, behavior, autistic traits, what we call neurodevelopmental symptoms and sometimes disorders, they are not the same. They occur very often in your children, and they represent a major concern. And as you know, and as we know, they are burden drivers for patients and caregivers in many senses. We have to try to shift some paradigms that we have. We like to compartmentalize cognition and behavior, but they are all together. And if we do this, if we understand that behavior is a domain of what we call cognition in a broader sense, we will understand better some of the behaviors that our children have and our adults also have with Lennox. And this is true until a certain level if you have mild and moderate intellectual disability. But when you have severe, it's not the same. And the thing is, when we use medications, and that's the importance to understand measures, is that sometimes you improve seizures and you improve cognition, what we call cognition, alert, but not always behavior. Sometimes there is a deterioration in behavior because a child that is functioning as severe, with a lot of seizures, may function as moderate or even mild, and then the behavior may get worse because this complex interaction starts to work. We can discuss this later. But actually, after Tracy, I have to ask, do metrics measure? And I have to justify because I have the most expensive ticket in the room. I came from Brazil, so okay. Well, I think they do, but let me try to prove. Let's see two recent trials, cannabidiol and fenfluramine. CGI showed that they were good drugs and based on clinicians and caregivers. But when we look at quality of life and even what we call adaptive skills or cognition, then if you look carefully here, this is for Dravet. Lennox is not even in the table, is in the appendix because they knew the results. We see that CGI, there is an improvement, but when you look in quality of life, using the quality of life of childhood, the epilepsy questionnaire, there is no improvement. And when you look at Vineland composite standard score, there is a decline. In fenfluramine, quality of life, there is an improvement. But this is PEDS-SCO. And if you look more carefully in this table, you see that using the same instrument that was used in cannabidiol, quality of life did not improve. So it's all about metrics. Or we have to conclude that fenfluramine improves cognition and behavior, and cannabidiol does not. What do you think? I think it's about metrics. And we saw yesterday UCB showing the results for Lennox, okay, with fenfluramine. And they use the scales like brief and for metacognition and subdomains that will favor, and they are right, it's clever to do this way, they will favor to show real data, real, they will not underestimate your children. This is the importance. So this is the agreement that metrics matter, and according to your recent papers, they do, according to your perception as caregivers, they improve with cannabidiol, they improve with fenfluramine, not all, but some. Okay, but it's easier to criticize, and as I said, I have to justify, so let's try to make something of this. Let's try to propose something. And we live in our bubbles, and we live in the epilepsy one, and we have these big names in epilepsy, and then we are very in our comfort zone, but then sometimes we have to move. And then when we go to another planet like neurodevelopmental disorders, we'll see that things are there, and they have been there for a long time. There are great frameworks, you just have to choose, and they basically say the same. You just have to leave your comfort zone, and it's tricky. Then I try to summarize some of the main things of these frameworks, and you know why I chose these topics. First, the classic neuropsychological assessment is not good enough for your kids or for your children with Lennox-Gastaut. They were not created or designed. They will underestimate children with Lennox-Gastaut and intellectual disability in children, so we have to adapt. And adapt means using adaptive behavioral scores and scales. They have strong psychometric properties that were validated in decades, and they were validated with thousands of individuals, not hundreds. It's a major difference. The most frequently used is violent and has to be applied by someone who is certified, trained, and has experience. Why I'm saying that? Because in the clinical trial, madness, not redness, that we are living, these children are receiving, these parents and caregiver are receiving forms and forms and forms, and violence is one of these forms. And it's so wrong. You see why you provide wrong response, even with the best wish, and because it's impossible to know what they wish. You will see. Okay, so violence is interview, and in this moment it can be online, it can be remote. Is it enough? No, we have to see the patient. And then we have Bailey, we have Peabody, we can use whatever, but you have to be trained and certified, because Bailey is like a lot of toys, but you have to put these toys in a certain position. You cannot put in the wrong position or in the wrong sequence. Otherwise, you have the wrong results. And if you can examine this child face by face, why do you need to interview? Because Bailey is heavily based on verbal expression. So again, we underestimate our child. We underrate our child. So there are no shortcuts. If you want to create a protocol, you have to grow step by step, and there is a certain sequence. They all have strengths and limitations. The strengths, in general, they have strong psychometric properties, and they will detect developmental delay very, very early as possible, and they will track improvements if properly used over time. This is what you wish. The limitation, they are not disease specific, although they are changing a little, but they are not supposed to be. Okay, it's not only about the instrument, it's also about who can use this instrument or who can use this question. We have to know our patients. I have authorization to use images of these patients. So I have Elisa, a CDD case with Lennox now, and I have Raphael, a Lennox of unknown etiology. They both have Lennox, but when I apply Vineland, and then you see why it has to be applied, interviewed, you see the difficulty. I have to know them in advance. I have to plan. There is 2 questions in Vineland about using the knife. One is about motor coordination. The other is about behavior and social. Raphael will not be able to use in the social, but he has motor coordination, and I have to explain to his mother. He's not using a knife, okay? He's not using scissors, and I can understand why. But can he grab things? And she said, of course he can. So in motor, he is safe. He doesn't lose points. And these points are very important when you want to compare the evolution of this patient using any type of therapy. But Elisa has cortical visual impairment. Even if you know CDKL5, you know that she will not be able because of lack of this type of coordination. Do we fail when we don't know these things badly? Let's learn with our mistakes. We mentioned yesterday the Estelle trial. That's a beautiful design trial, blinded, unblinded, and then the assessment in 3 different moments. And the instrument chosen is the toolbox for Cognition age toolbox. That's not only for crystallized intelligence, but also for fluid intelligence. And it's perfect. It's about attention, it's about memory, it's about language. It's a good instrument for people with intellectual disability, but didn't work. Why? Because it's completely tablet-based. And based on your own data, patients with Lennox-Gastaut will have difficulties not only to touch the screen, but also to move with fine motor skills. So we have to know our patients when we propose something. And even in behavior, as I mentioned before, behavior and cognition, they are together. So ABC is the only validated instrument for behavior in epilepsy. So it's a reliable. CBCL that was used in clobazam, we are not supposed to use it in these children because there are a lot of domains that imply in understand something and go against. It's about conduct disorder. It's about externalizing behaviors. And these subdomains we should not use. And then what do? We exclude, okay? The last part, I think you have heard a lot. I am very careful with time because I had a lot of warnings yesterday, so it's about scores. You have heard a lot about raw scores and growth scores, and they are really important. But let's understand scores. They are hard to explain with words, but they are easy to understand with images. In early infancy, it's easy to compare children. If they don't have a DE in the neonatal or infancy period, okay. But later on, there is a difference because a child without intellectual disability will achieve things in a different rhythm. And a child with intellectual disability will be slower, because actually this word intelligence, or IQ if you prefer, I don't like it, but anyway, is your ability to learn as fast as possible. So this is not fair. The standard score is not designed, is not supposed to be used for children with intellectual disability. And this has been very well demonstrated by Scott Perry in Dravet, and also by Anne Berg in SCN2A. If you use a standard score, then these children will have a decline. It seems like a deterioration, and this is not true. However, if you use raw scores and you break down, then you have a real vision of the subdomains. And we are not supposed to use composite scores. It's a limitation of these instruments. It's called structural validity, and it's a limitation. It's not good. Subdomains, you can see better that this child in communication has lower scores because of writing. But writing will not improve. It's not a major concern, but it is improving in other aspects. The same graphs I have with SYNGAP, because we are studying SYNGAP, and it's the same. And what do I do with these domains? Well, if most of your patients cannot perform well, if they have a floor effect, you remove them. You just assume those that your group can do, because this is what you have to track over time with precision or unprecision medicine. It doesn't matter. Over time, you need them. And this is what the CDKL5 group, Lulu, has done. They used 10 instruments. They adapted 10 instruments for 100 children. And they have now 6 instruments. Some subdomains will be used. Finally, the frenzy, the enthusiasm about having your own tool. And this is based on some disease-specific instruments that were created for disorders that should not be compared with DEs or with Lennox-Gastaut, like lipofulcinosis type 2 or any type of lipofulcinosis. The outcome here is death. So anything is better than death. That's why the NEI, the FDA, and the European agents allow historical controls, and a composite score with language and motor is not the same for you, and it's not supposed to be. And then we had a plethora of new instruments. It's a huge amount of work, and they are validated in hundreds. They are not validated in thousands. That's why some of these instruments are being validated for the second time, and they don't have longitudinal validation. 2 years is not longitudinal. So be careful. What happens during clinical trials, if you have one disease-specific instrument, I'm not against them, just telling you what happens. Let's see Angelman syndrome. Angelman syndrome has one specific CGI that is interesting to improve the sensibility of CGI, but then communication is the same, CGI new, CGI old. And then you have to improve the sensitivity. And we use ORCA Angelman, but we cannot use only ORCA. Then you have to use Vineland and Bailey, meaning a lot of more burden for parents, caregivers, and doctors. And about the FDA guidance, it's quite boring. That's why I made this presentation. I just presented the FDA guidance for you. Everything in the FDA guidance it's already presented in this 18 minutes, as I promised to Tracy in 18. It's already done, and I think in a more pleasant way, okay? So you don't have to go through the same pain that I had to. And I accept the day 3. I'm not North American, but I have to say, I am American from the South, so we are all the same, that your voice and your talks spoke to my heart and made me remember why I am involved with the ILA and creating guidelines for you. And that should be the reason all the time, and we have to be remembered because there is so many politics involved. But people like you make people like me remember why we are there. So my day 3 is to finish the guidelines. Elaine, you are involved. So it's your day 3 too, in 2026, and perhaps a checklist. Who knows? I was discussing with Elaine. It's not so complicated because checklists are supposed to be instruments that are not perfect. They are screenings. So at the end of the day, it's nice to create something that's not perfect, okay? But it's helpful. Thank you very much, and thank you for having me here.
Any questions? Thank you for staying on time.
Thank you.
She had like 50 slides, but she did beautifully.
Yeah.
Perfect. Right there.
Hi, thank you so much for that. As a developmental psychologist with training in neuropsych, this really spoke to me. And what I wanted to do was just voice over a few things that training, I think, allows me to comment on. The first is, I think that people with training like I do are hard to come by, but are very good at making appropriate adaptations. And so I think where it's appropriate and possible, partnering with people who have that training can be really impactful, both in terms of clinical care, also in terms of trial design and execution. And I think the challenge here, which you articulated quite well, is that there's both the quantitative aspect and the qualitative aspect, right? And so when you're in a clinical trial and you need to track things over time, you need scores, or you need averages, or you need things that you could say. There's a relative or absolute change between X and Y. But I also don't want people to lose track of the qualitative components of an assessment like this, which I think are really important when you're looking at some of these subtle nuances and also the heterogeneity of this illness. So thank you so much for that.